Morning, everybody.
Good morning.
How are you doing? I think we have one or two more people we're waiting for. So. I like my blurred background.
Yeah, it's fancy.
Very mysterious. I could be anywhere. One more minute, we'll get going. All right, may as well just get going here. Okay, we ask Perna Bonsall. Perna, this is atrial extrastimulus testing. This is cycling 500, and then an extra stimulus is put in at 250 milliseconds, inducing tachycardia. Can you tell me what kind of tachycardia this likely is?
I am looking through its AHV, and then after the stimulus testing, extra stimulus, it becomes HAV.
You see here, just for your own edification, that the R to R interval is 330 milliseconds. So a rate in probably about the 180s, something like that, 190 range.
Mm-hmm. So let's see. Here we start off with A and then we go to V. After the extra stimulus testing, if I look at I am not sure what does this legend mean above, just above coronary sinus.
Okay, so let's just for the sake of clarity, we have 4 ECG leads. We have high RA. Sorry that the H was cut off. This stands for His bundle electrogram. I unfortunately cut off the H, and there's only one coronary sinus lead, presumably proximal coronary sinus.
And if we are starting off from, and then after the extra stimulus testing, as it's mentioned in the His catheter, the H comes before the A and then V. It means it's junctional ectopic tachycardia. It's starting from the His because it's preceding the P wave, I would think.
Okay, so you're suggesting that this is a junctional rhythm of some sort.
Yeah.
Now, do junctional rhythms, are they normally automatic arrhythmias or reentrant arrhythmias?
Automatic arrhythmias.
They're usually automatic. So are automatic arrhythmias usually started with extra stimulus testing?
No, it's
it could be. I don't want to say that there's no possibility. Some are, but generally speaking, you're correct that reentrant arrhythmias more commonly are started with extra stimuli testing. In fact, that's one of the definitions, is that an extra stimulus can induce it, and automatic arrhythmias not so much. So. Okay, so this could be junctional, but what else could this be?
I'm a little confused because of the sequence that we have H and then A and then V.
So how do you determine whether, I mean, most of the time for SVT, what are the two most common diagnoses we are dealing with in 95% of the cases?
ORT and AVNRT.
Right. So what's the big distinction? Forget about looking at the tracing. If I just said to you, what's the one thing in tachycardia that would distinguish the two on the surface electrocardiogram? What would you say that is?
RP intervals. If the RP interval is more than 70, then it's ORT. And if it is less than 70, then it's AV and RT.
Right. So what do you
So,
make of the R to P interval in this case? You don't have a P wave, but you have an A wave, which is a good surrogate for a P wave.
right. So here, I mean, the RP interval, it looks, so the RP interval is definitely more than 70 milliseconds here, I would say,
You
looking
think
at the
so?
trace.
Well, look what's
If I-
happening in the His, Berna. Which is coming first, the A or the V?
The A is coming first.
So what does that make the R to P interval?
So the RP I would consider from V to the subsequent A. So that would be more.
Okay, that's one way of looking at it. Another way of looking at it is that the RP is negative, that that A is preceding the V. I agree with you. It's possible you could say that this is a very long RP interval. But if that were the case, then the A should still precede the V, because there's really no way for if it were going down the node and up a pathway, right, then the His to A interval should be much longer than this, right?
Right.
Basically, what you would be saying is we're going down, that this A is going down the node to this V, except we're seeing an A before the His has even depolarized to the V. So it can't be coming from here, from this beat, right? In other words, if you're going A, H, V, and then going back up a pathway, the A has to occur after the V,
Right.
right? So this
If
cannot,
it's
so it's actually can't be a long RP interval.
okay.
So when we're putting in the extra stim, the first thing we notice is that in the drivetrain, the AH interval is normal in appearance, right? I mean, we haven't measured it, but if this is 250, I think we could surmise that this AH interval is in the range of about 50 to 60 milliseconds. Then we put an extra stimulus in, and we have a very long AH interval, right? Goes from like 50 or 60 to 300. So
Right.
what does that generally imply to you when you have a big increase in the AH interval?
That twin AV node physiology.
Not twin, we say dual.
Dual, sorry,
Twin
dual
AV
AV.
nodes is a term we use to denote patients who actually have two AV nodes,
Right.
which is a condition typically seen in occasional patients with heterotaxy syndrome. Okay, so we have to use our terminology carefully here. Now, I will remind you that when you put an S2 in at 250, of course, the AH interval is going to be much longer than it would be pacing straight at 500. So this is not definitive evidence for dual AV node physiology, but I think that this is a good hint, though. This AH interval, even at 250, is very long. And so then what's happening is we're going down the AV node, hitting the His, and reentry is occurring in the AV node, back up the A, and is also going, remember that in AV-NRT, the reentry is above the level of the His. And so basically you have reentry in the AV node. And then the A goes from the AV node, it goes retrograde up to the A and antegrade down to the V. And in some patients, the time it takes to go from the AV node to the A is shorter than the time it takes to go from the AV node through the His and the V. And in this case, actually, the A is occurring before the V, meaning that the time it takes to go from AV node to A is faster than it is to go from AV node to V. So this is actually, if you want to think of this as the onset of the R, the QRS or the QRS, here's the R wave, it's clearly negative, or at very least, it would be fair to say it is less than 70 milliseconds. This cannot be an A coming from the pathway, because if it were going from the A to the V and it were coming up a pathway, it would have to, the HV interval would have, the HA interval would have to be much longer. In other words, the RP interval would have to be longer than this. And this is, there should not be another A before. If this A were coming from here, going up a pathway, there should not be another A before the V. So this is an example of AVNRT. Let's look at, let's ask Dr. David Barris. David, this is a tracing that we've obtained in a postoperative patient and doing an EP study on this patient, and this is what we have found. Tell me if there's anything wrong here or if it's normal. Is there anything we need to do about this?
Yeah, so it looks like the AH interval is pretty long at 250.
Mm-hmm.
And then the HV looks like it's more, it's a normal length at 45 there.
Right. So a normal HV intervals are roughly 50 milliseconds. And
So I guess we could call it like a first degree heart block.
right. So is this the common, when somebody has a long PR interval following open heart surgery, would this be what you would normally expect if you did an EP study on these patients?
I'm not sure, but the way you're asking the question, I'm going to guess that it's usually not. It's usually the HV that's longer.
That's right, because remember that generally speaking, injury to the conduction system from surgery is injury usually to the his Purkinje system. It's usually infrahischian, not suprahischian. Okay. And so it's not a guarantee. Obviously, anything can happen in any body. But the bottom line is that if you see a long if you have if you have AV conduction injury from surgery, typically it is infrahischian, meaning that the HV interval will be long. What is a normal AH interval, David? Just for reference sake.
Is it like 50 to 130?
Yeah, that's about right. That's about right. So this is notably long. And every once in a while, we put somebody on the table to do an EP study or an ablation, and we see something like this, and obviously it causes a little bit of trepidation. You know, patients who have AVNRT sometimes will demonstrate this on the table because they're going through their slow pathway at times. And actually having a long, perhaps not surprisingly, having a long AH interval at the start of an AVNRT slow pathway modification is a risk factor for the development of heart block during ablation, which is not shocking that you would see that. Now, sometimes when you modify the slow pathway, the fast pathway will improve, but that is not a guarantee. And I remember very well early in my career, a case working with Dr. Hordoff at Columbia, where we had a patient like this who had a pre-existent very long AH interval. And we did a very, very conservative slow pathway modification. Thankfully, nothing happened to the conduction. But I remember that because we had trouble explaining this to the mother, she was very angry that we had not been more aggressive about ablating, not understanding the risks of heart block. I guess it wasn't explained adequately to her, but anyway, it's important. Okay, so this is a 5-month-old who has a VSD repair with RV outflow resection and arrives from the operating room in what is referred to as a nodal rhythm. And there are no A or V wires. This is an old tracing from many years ago. Dr. Quagabord never liked to put wires on people's hearts for some reason. So it was not uncommon that you'd have to manage these patients without them. Patient was on low dose dopamine. The rhythm was intermittent. And here's an example of the rhythm. And eventually it became sustained. And there was some hemodynamic embarrassment associated with this rhythm. So what would you do about this? So let me ask Dr. Sergey Babia.
Good morning.
Nice to meet you.
So what are we going to do with the jet?
Well, let me
Right.
ask you first, since you've made an assumption that it's jet, and I'm not disagreeing with you, but how would you confirm that it's jet? Because is this a wide or a narrow QRS tachycardia?
Well, this is a looks wide, but the more important thing is that it looks exactly the same as the QRS before it went into this tachycardia.
Right. But can you say that I agree with you that in this lead, it does look exactly the same? But does that mean it is exactly the same?
Uh, you mean that in other leads it can look differently?
Yes, it's what I mean exactly.
um, so of course we would get an EKG at 12 lead EKG.
Right. So we would
Since
want to get a
we're
12 lead EKG. So if the QRS morphology looked exactly like the sinus beats, I agree with you that the most likely thing here is that this is jet. But if it did not look the same, then it's more likely
could be
ventricular.
VTAC.
Then it's
Yeah.
VT, right? So what are you going to do about this? You don't have any wires, Sergey.
Right. Well, I guess because there's hemodynamic embarrassment, I would, and since I don't have, do I have a way of proving that this is not a VTAC, or I
Well,
don't?
you just explained it to me. You're going to get a 12 lead.
Right. So I have time to get the 12 lead.
So you get the 12 lead and the 12 lead. Well, hemodynamic embarrassment is relative.
Mm-hmm.
Patient is, mildly hypotensive.
Okay.
Left like this, things will not go well. But you do have a few minutes to come up with a plan. So you've done your 12 lead. You've convinced yourself that the QRS morphology is exactly the same as the sinus one. And by the way, this is an interesting time to just mention that this is one of the reasons why it's always useful to get an EKG relatively early after the patient arrives from the unit, because most of the time anesthesiologists will try to drop the patient off in the unit in sinus rhythm. And jet often comes later, usually a couple of hours after you arrive. So having an EKG in sinus or atrial paced rhythm can be very helpful, particularly at a time like this when you're trying to make an accurate diagnosis in order to treat the patient. So just always keep that in mind. And, we don't have to be crazy about it. In other words, you ought to let the nursing staff do all the important things that they normally do. The sign out has to be done, but one of the first tests that should be done once the patient has been plugged in and is stable and the nurse allows it is to get a 12 lead EKG, or at the very least, a limb lead EKG, maybe with one precordial lead. Typically V1 is helpful. Okay, so we have those. We've compared them. I agree with you. This is jet. So what are you going to do? You don't have any wires. The patient is getting a little hypotensive. You haven't had any urine output for the last hour. The nurse is very nervous. You're on with a non-cardiac intensivist, so you have to manage this. Okay, so what do you want to do?
Well, I'll start with cooling the patient,
Okay.
and then
How cold do you want to make the patient, and how do you want to cool the patient?
we could use the cooling blankets. We should
Okay.
do continuous temperature measurement with a probe, and we would cool to about 35 Celsius.
That's right. 35 Celsius is typically the right temperature to do this to, and you would cool them. And I'm very pleased by your statement that we would have a continuous temperature probe. You do usually want to have a rectal probe of some sort to do this. And the reason that's important is it's very easy to overshoot and make somebody too cold. What happens if you make them too cold? What's the risk if you got to, say, 32 degrees, Sergey?
You're going to make them more acidotic.
That's definitely true. You can definitely make someone acidotic, a big
And then-
lactic acidosis. Anything else that could happen?
Yeah, I remember you always tell us that they might start shivering, and that increases the cardiac output, which we don't
Well,
want.
it does. It uses cardiac output, which
Right.
is bad.
It
But you know
uses
what?
cardi-
You're
right,
going
right.
to shiver. You're going to shiver at 35 degrees also, by the way. But that's true. At 32 degrees, you really will shiver. Anything else that could happen from cooling someone too cold?
Right, and I believe that you can cause more, even worse kind of electrical issues.
The most important being VF.
VF,
You
yeah.
lower the fibrillation threshold quite substantially. In fact, that's part of the way that hearts are stopped to do bypass surgery, right? Is they cool the patient down, and making them cold makes it very easy to fibrillate and stop the heart. Okay, so you have to be very careful about that. I think I've told you this story that years ago, when I was a resident, I properly and just luckily it made this diagnosis in a patient of mine in the early 1990s, when there wasn't quite as much knowledge about this, though I had literally just read a chapter on it the night before. And I said to the attending physician, well, we have to cool the patient. At that time, we didn't have cooling blankets. We would gastric lavage patients. And I got the patient down to like 33 degrees Celsius. And when we walked in the morning, the heart rate was like 85, and we had good blood pressure, and we were urinating. And I walked away that morning after being on for the night float thinking I was a real genius. And I had I had gotten control of the rhythm and the patient was doing well, but what I didn't realize was that I was teetering on the edge of ventricular fibrillation the whole night. Not real, because I just didn't understand enough about this. Also, gastric lavage with ice is a very bad way to do it because it can cause terrible electrolyte abnormalities. So today we would never do that. We would instead use a cooling blanket where we can more carefully control the temperature. Okay, so now you've cooled the patient to 35. Anything you want to do to the patient now that you're 35 degrees? You talked about shivering. How do we control that, or how do we manage that? First of all, why, again, just to reiterate, why is shivering bad?
Because it takes up the cardiac output.
Right, exactly. It's somebody like this, we're in low cardiac output. So the last thing we want to do is use cardiac output for shivering. Okay, so how are you going to treat the shivering or prevent shivering?
We can sedate and paralyze the patient.
Yes. So traditionally in the past, we used to say you must sedate and paralyze the patient. But I've noticed today in many units, they don't paralyze as much anymore, but they do sedate heavily so that they shiver less and are not uncomfortable or not as aware of being uncomfortable. Okay, so you've done that, and the heart rate has not changed much. So what would you do next?
So then we have two options. We can use either procainamide or we can use the amiodarone. Since we've cooled the patient already, we can use the procainamide because that's the one that we need to cool the patient first.
That's right. So how much would you give the patient, Sergey?
So for procainamide, it's going to be 5 milligrams per kilogram.
Right. So it's interesting. It's actually easy to remember because the first dose for both amio and procainamide are both 5 per kilo. But the thing about procainamide is really the effective dose is normally in the range of about 10 to 20 or 10 to 15 per kilo. So the reason that I normally like to give 5 per kilo is actually based on a conversation I had with Elizabeth DeWitt at Boston Children's, where she explained to me that what they do is they give it 5 per kilo. And if it's ineffective, they give another dose of 5 per kilo, and they typically give that over, say, a half hour. And the reason that they do that is because of the hypotension that's associated with vasodilation from procainamide. And in amiodarone, if you look at PALS, it says that how fast does it say to give 5 per kilo of amio when someone's in VF?
Faster than we would usually do, I think.
Right, like 20 minutes, I believe, is what it's recommended in PALS. But we would not normally do that because that can cause very serious hemodynamic embarrassment. So normally we would give 5 per kilo over an hour or something along those lines. So that's basically what you would do, is you would do one or the other. Probably, if you're already cool, I would agree with you, we would give procainamide and see what happened. And usually, in the vast majority of cases, procainamide will be effective with cooling for this. Okay, so this is a 6-year-old who's referred for an elevated heart rate, and I'm going to ask Grace Kong, what she thinks is going on in this trace.
Hi, good morning, Dr. Paul.
Hi, Chris.
So looking at our tracing, we do have P waves that are down in AVF and in 2. There is a P before every QRS, and the PR interval seems stable. Our heart rate is a little bit faster than 150, 160s. It's a 6-year-old, definitely tachycardic. So it's a non-sinus tachycardia coming from some kind of supraventricular. I'm tempted to call it EAT. And let me look at the rest of I just looked at the P waves, otherwise the axis is normal. T waves look fine. Yeah, I think I would call it EAT.
Okay, so I agree with you. EAT is definitely in the differential diagnosis of this arrhythmia. Is there anything else that would be in the differential diagnosis of this? So you're calling it EAT because you're seeing a P wave that precedes each QRS, and because the P wave morphology and axis is completely different than a sinus P wave. Am I correct in stating this as your rationale for choosing that diagnosis?
Yes, that's correct.
Okay, I just want to make sure we're on the same page. Is there anything about this that does not go with EAT? I agree with you 100% that that is absolutely a possible diagnosis here. But is there anything about this that might suggest otherwise?
The PR is short. You would generally expect it to be longer.
That's right. That's the only thing I wanted to make. That's the only other point I wanted to make is not always, but oftentimes people with ectopic atrial tachycardia, or what it's sometimes called atrial ectopic tachycardia, have a long PR interval, have first-degree heart block when they are in tachycardia. But that is not a guarantee. And in fact, in this particular case, if this were EAT, the P waves are inverted in the inferior leads, right, in 2, 3, and F. So that would imply that a path that the focus rather is coming in the inferior portion of the atrium, close to the AV node. So this might be one of the examples where an EAT is actually not near to the. I'm sorry, it is not associated with first-degree heart block, right? Because it's physically closer to the AV node, and so the PR interval will be shorter. What else is in the differential diagnosis, though? So I agree, EAT, absolutely important potential diagnosis here.
Could you have like an abnormal cardiac position, mesocardia, or it doesn't look like dextrocardia?
Say that again. You're wondering if this is dextrocardia? Is that what you're saying?
No, I don't think it looks like because P wave is upright in 1, but some kind of mesocardia, some kind of abnormal cardiac position.
Okay, that's an interesting diagnosis. But
I can't think of it.
I'll stop playing the Reed Rob's mind game. I mean, the other possibility here is that this could be PJRT, right? So in PJRT, what is PJRT?
Oh, yes. It's a reentrant tachycardia with a very long RP.
Right. So in PJRT, which stands for the permanent form of junctional reciprocating tachycardia, I'll remind you that that is a misnomer. Really, it's like a form of ORT with a very slowly conducting concealed accessory pathway, typically has a long RP and a normal PR, not unlike this, right? The RP interval here is like nearly 200 milliseconds, and the PR interval is, if anything, is normal or even short. Often results in chronic tachycardia, which can cause ventricular dysfunction, not unlike EAT. And it's typically a posterior septal region near the mouth of the coronary sinus, which of course is inferior. And always the differential diagnosis for this is EAT. And the treatment is catheter ablation or medications. And from this tracing, it would not be possible to know whether this is EAT or PJRT. One could really only figure that out in the cath lab. You could give a dose of adenosine if normally PJRT will be terminated at least transiently with a dose of adenosine, whereas EAT will not. But there are cases of EAT that are sensitive to adenosine. So the response to adenosine is not a very robust black and white answer that can definitively distinguish between one and the other. So just mention that. That was good.
Dr. Pass, the rate of PJRT generally is this slow as well, can be.
Yeah, remember that the PJRT rate is slow because the pathway conducts very slowly retrograde. So by definition, PJRTs have to be slow tachycardias. And because they're slow, patients often don't feel them, which is why they come in with ventricular dysfunction oftentimes, why they can cause dysfunction. And remember that the reason that PJRT was considered to be quote unquote permanent, hence the P, PJRT, is because, why is it that patients who have accessory pathways, let's say a concealed pathway, do not have SVT all the time? This is a very important concept. Why are our patients not in SVT all the time if they have a concealed pathway? Well, in sinus rhythm, right, they go from the A to the V through the AV node. The ventricle is depolarized, and then electrical conduction goes retrograde through the pathway. The reason that you don't have tachycardia, and by the way, this happens every single beat of the heart in somebody who has a concealed pathway. There is always conduction from the ventricle up the pathway. The reason you don't have SVT, though, is because the conduction up the pathway and through the AV node is so robust that the atrium is still refractory from the sinus beat that just preceded it. And so even though on every single sinus beat, there is an attempt to go from V to A through the pathway, because the AV node and the accessory pathway both conduct robustly and quickly, the atrium is refractory, and therefore you do not go into SVT when you are in sinus rhythm. However, if you have a pathway that conducts very slowly because of its conduction characteristics, as in PJRT, then it's very easy to go into SVT, albeit a slow form of SVT, because what happens is that you're in sinus rhythm, you depolarize the ventricle, and then the impulse does conduct retrograde through the accessory pathway very slowly back to the atrium. And by the time the impulse reaches the atrium is no longer refractory, and then you have a slow form of atrioventricular reentry. Does that make sense? So that's the reason why people appear to be permanently in tachycardia, because in a sense they are, because the factors that would allow you to have SVT are all there. Remember that one of the main components of reentry, one of the three requirements, remember you have to have three requirements, and one of them is a zone of slow conduction. And that's because if you don't have a zone of slow conduction, the other pathway will be refractory. And so in this case, the slow conduction is through the accessory pathway retrograde. And it's so slow that the atrium is no longer refractory, allowing for reentry to occur. Okay. And oftentimes these have to be ablated. You can try medication, sometimes it works, but they can be challenging to control medically. Okay, this is a text message that I received last week. Hi, Dr. Pass, the AV canal, who is post-op day 7. Actually, this was not last week, but not too long ago. Status post-repair is having brief runs of what looks like blank at a rate of 190s this evening. She is hemodynamically stable. Dr. X does not think treatment is needed, but we wanted to let you know. So I appreciated this informational text message. This is the tracing that the patient had. So I'm going to ask Dr. Neha Lawalia, soon to be.
Morning, Dr. Pass.
Morning. What do you think we're looking at here? And do you agree with Dr.
X?
X to not treat this arrhythmia?
So in the first picture, the first 2-3 beats have P waves with the QRS complexes, and then you don't have P waves for the next couple of beats. Again, then there's some beats with it and without it at the end of the strip. And on the lower rhythm strip, it's similar that there's P with every QRS in the beginning of the strip. The QRS complexes look similar in with and without the P waves. They're slightly wider, but again, it's probably post-op related. So I would say that there is sinus rhythm with intermittent, possibly junctional tachycardia. Yeah, I think that's what I'm.
Well, it's possible, certainly possible. One
I mean,
of the
I
things
can't
that
see the
what else
PV.
could
Yeah, yeah. I mean, I don't
what else could
see.
this
This could be EAT as well. This could be I don't know, sinus stack where you can't see the P waves that well, but it would be interesting because it's just sudden on and off between, so that would be unlikely, I would think.
right?
Um,
Right. So
so
I
it's
agree
some sort of re-entrant, it's like on and off in the
wait,
middle.
you're saying it's reentrant, but you then said, you said you
Yeah,
thought
then I said EAT. Yeah, I know I'm contradicting
junctional and
myself.
EAT are both automatic arrhythmias, right?
Right.
So this is not reentry. This is, you notice how it just sort of slowly just accelerates into it on and off. So it's possible it's reentrant, but it's unlikely. I mean, this rate is a little slow for reentry in an infant, right? What rate should reentrant tachycardia be in an infant?
Like 300.
At least 250, right?
250, yeah.
At least that, but yeah, it could even be as high as 300. So this isn't quite as fast. So I agree, the differential would be JET or EAT. And I think this is an important tracing because, I'm always teaching you that automatic arrhythmias sort of slowly come on, slow onset, slow offset, but it's not always the case, right? And I think this is an example of that. Now, you initially said this could be JET. How likely is it that somebody would have intermittent JET on post-op day 7?
Very unlikely.
It's pretty unlikely. It's not unheard of, but it's a little unlikely, particularly if the patient had, I didn't tell you this, but patient had no prior history of JET after surgery. So, just in terms of common things occurring commonly, I think the likelihood is that this is an ectopic atrial tachycardia. And the other thing is you could convince yourself maybe that if you look at these sinus beats and look at the T wave, and then look at these tachycardia beats, I think you could convince yourself that the T wave is
pointy,
yes, and a little taller maybe than these T waves. So you could probably convince yourself that there's a P wave buried in this T wave. So this is a form of ectopic atrial tachycardia that occurred, and that, as you all know, and many people have made this observation in recent past. It seems like we're seeing ectopic atrial tachycardia very frequently in patients following open heart surgery. And this was not seen even as recently as 5 to 10 years ago. It's very unusual to see this. In fact, if you look at a textbook from, say, 15 years ago and read a chapter and on SVT and read about EAT, it'll tell you that EAT is largely a disease of people with structurally normal hearts. And yet, I think it would be fair to say that in the present era, the majority of EAT that we see are in post-op patients who have congenital heart disease that has been repaired. And nobody seems to understand why it is that we're seeing so much of this, but we certainly do. What would you expect is the natural history of this? So the mother is very nervous about this. Her baby is having all this tachycardia. What would you tell her in about what you expect is going to happen with this arrhythmia if this is EAT in a post-op?
I would expect a good prognosis that this should get better in the next few months or up to a year. Yeah.
Yeah, that's right. It normally will get better. And usually, as opposed to many EATs, so the earlier you are when you have EAT in life, in other words, the younger you are, the more likely it will self-resolve. So if we see EAT in small infants, we're usually very optimistic it's going to go away. If you see someone over a couple of years of age, the chances are actually fairly low that it's going to go away. In a post-op patient, I don't think we've ever seen one where it persisted forever. They usually do go away, which is part of the reason why you don't see me jumping at the opportunity to ablate these, because we know that the natural history is that they will almost always burn out eventually. So this could be treated in any number of ways. One could put them on amiodarone, sotalol. You could be on a beta blocker potentially. A lot of different things could potentially work for this. And in fact, this patient ended up having a lot more tachycardia. And so we had to overrule Dr. X and start medication on this patient. All right. Just go to, this is our last tracing. This is an example. This is an old tracing that I found on the internet about 12 years ago. And it's from the Tehran Arrhythmia Center. And I just thought it was funny. Dr. Magarefte at that time was a fellow in cardiology. So I thought I'd share with him some of the latest work from his home country. So I'm going to ask Dr. Barris to finish out this conference, to tell us what you think is happening in the atrium. And before we go forward, let me just remind you that these are the three surface ECG leads. This is a right atrial lead. There's two pairs, distal and proximal. This is proximal and distal His. And finally, this is RV distal. Always remember when you're looking at any intracardiac tracing, first look at the legend on the left so that you know what you're looking at. And this is VT. So what's happening in the atrium?
Well, I'm just kind of starting with the ventricular lead, just because you've mentioned already that it is VTAC. And in the first beat, I see at a cycle length of 350, the ventricular beat followed by the His, and then the atrial beat follows it. So I would guess it's like a retrograde conduction to the atrium in that first beat. In the second beat, I see again, now it's a cycle length that's short, that's 310 now. And now again, I see His. I do see two deflections on the His catheter that are a little bit more separate from one another than the first one. I'm wondering if that's the and then now I'm seeing again after that the atrial deflection. I mean, for me, it just looks like it's retrograde conduction to the atrium, but I'm guessing that there's something else that we're going to talk about.
That is true, David. That's very good. There is retrograde conduction to the atrium, but is it the same from beat to beat? In other words, what's happening in this beat in comparison to this beat, and then finally this beat? These three beats are different from one another, and they represent a certain form of conduction. That is the question I'm asking.
So I guess that
this is a V and this is an A, because we're in the His, right? So in the His, we should be able to record A, V, and sometimes His. So this is the V, and we know it's the V because it's corresponding to the QRS, which is wide, and this is the retrograde A corresponding to the high RA A. So what do you think is going on?
So are we getting decremental retrograde conduction through the His?
That's right. That's exactly right. And what we're seeing is retrograde Wenckebach. So we have here a short VA interval, okay? Then the VA interval gets much longer as the tachycardia accelerates. Then this VA interval is even longer still than this, right? And then finally, there's a V and no A. And then the cycle begins again. We have a V and an A, and then the VA interval gets longer, and then we don't see what happens on this tracing because the government did not allow us to see further tracings from the Tehran Arrhythmia Center. But the bottom line is that this is ventriculoatrial Wenckebach. So just like we can have atrioventricular Wenckebach, you can have retrograde conduction Wenckebach of the AV node as well when you're in VT. And we see this sometimes when we just V-pace, we can see VA Wenckebach. When we see VA Wenckebach, when we're straight V-pacing, that's a good indication that there is not an accessory pathway, because remember that accessory pathways do not decrement and AV nodes do. So in this case, we're in VT, but we're having one-to-one VA conduction, albeit Wenckebaching through the AV node. So, all right, I think with that, we'll stop. I really appreciate everybody joining, and I will see you in conference in just a few minutes.
Thank you, Dr.